Hi everyone, this is the third part for Exam 1 for 212, and remember you have the other part, PNS, or Megan's piece. This one we're going to talk about poisonings and overdose. Poisonings in general, the Poison Control Center is the place where it gets reported a lot of the issues here, and that's where I got this little graph from. The top 5 shown here are cosmetics, personal care products, cleaning supplies, sedatives, hypnotics, antipsychotics, which we hear more about because, you know, we're doing more to do with hospitals. When you go down to the types of poisonings, the unintentional category, then there's ages, all ages, therapeutic general, therapeutic error, 6 to 12-year-old range, and let's see, 6 to 12-year-old range where we have to be the most careful because of there's so many more errors. See how big the bar is there. You have to know that there is the 5 rights. You have to do double checking, and you have to be sure of every little thing before you give medication anytime, especially in the 6 to 12-year-old range. You see adults, the number 34%, unknown 5%, teens 8%, then we get to less than 6, 47%, 6 to 12, 6%. So that's just a little bit of that. Also, I put the Poison Control Center down there on the bottom. I'm going to pause for a minute and pull that up so we can look at that just a second here. Okay, here is this website from the bottom of that slide, the Poison Control Center, National Capital Poison Center. This is great to be aware of as a tool for you to be able to point people to when you're teaching, and these statistics might be the same ones that I have given you, I think exactly on this little circle. Children younger than 6 years comprise nearly half of poison exposure, followed by adults and then teens. Okay, so I was quoting you 6 to 12-year-old range, but really it's less than 6, and then it goes to adults. Then down here, I was looking at some of these categories by age group. This is where I found the unintentional general errors for 6 to 12. It's pretty high here, 41.9%. Also, you see it's lower right there for adults and teens. Really high for less than 6 years old. And then intentional, like for suicide, you have to look at those numbers sometimes. So this is a great place to come if you need these kind of statistics, also if you're having to write a paper or do anything like that. Here's the most common substances. Again, we talked about that. Okay, it was back here at the top of the site. We're on this page on the statistics, but if you go to this Act Fast, here's what you need to know. When you come upon somebody, or if you suspect a poisoning, it tells you to use the website online tool, get recommendations based on age, substance, and amount, or you can call the poison control phone number. And then here's what to do. Basic first aid. Seizure, swallowed poisons, poison in the eye, poison on the skin, inhaled. So this is really a good thing to review. We're going to be talking mostly about pills or IV and injections. You can get poisoned other ways. We saw some of those topical or inhaled. With inhaled or topical, think about people spraying in their garden or working in a garage with mechanics that use different kinds of chemicals spraying into their tools or into the engines, and you can get inhalation poisoning that way. Our focus includes the analgesics and sedative hypnotics, which is the broad category. Then we're going to talk about sedative hypnotics. We're going to talk about antidepressants, cardiovascular. We saw that list, household cleaning substances. We're going to deal with that a little bit. Pesticides, not at all. And then antihistamines is on the on our list too. But the things we're going to focus on are going to be some of those medications that we're going to be dealing with. So we're going on to high alert medications. These are from the Institution for Safe Medication Practice, and the reason they're high alert is because if there is an error with these kinds of medications, the risk to the patient can be very significant. The four big ones are anticoagulants. Think about heparin, warfarin, or Coumadin, risks of bleeding with those, and stroke. Insulin, you get hypoglycemic reactions. Narcotics and opiates causing sedation, so also respiratory depression, or can make you stop breathing, can decrease your blood pressure. Also sedatives and other analgesics add to the same category, decreasing your respiratory drive and lowering blood pressure. So we want to concentrate on making sure we are doing the double check when we are working with high alert medications. Some of the general priorities that we know we're going to need to do is providing supportive basic care first. Of course, we're going to look at the ABCs always. So airway and breathing and circulation. This shows up here. The pediatric patient maintenance of airway, breathing, circulation. Stabilizing the airway is always the first priority of treatment. This one is also showing alcohol poisoning. The patient is in a rescue position on that lower one. With alcohol poisoning, that's important so that if there's any vomiting, they're not going to aspirate. Well, with the ABCs, we know we're going to want to do the airway first, oxygenation, intubation possibly, then the IV access. You need the IV for fluids to increase their blood pressure, or for an antidote that may be given IV like naloxone for narcotic reversal. You want to get it in their system fast, so the IV route is going to be fast. They also have intranasal for naloxone. If they're having any kind of respiratory depression, that's a real important thing to get the IV. The third thing is to consider alternatives. Sometimes you know why there's an issue, or you don't know. If they come to the emergency room and they're very sedated, it can be from a lot of things, and you need to figure it out. You can't assume that one thing is making them sedated and decreasing their respiratory rate, for instance. If it's alcohol and it's alcohol poisoning, then giving them naloxone is not going to work. If they took pills, who was with them? Who knows what kind of pills they had? Was there a bottle nearby? Does anybody know how much was in the bottle? You know, all those kinds of questions you need to ask somebody who might have been with that person if they found any of these things in the area, so that you can find out how long ago it happened. How many pills they took, maybe, how much was in the bottle. That's all estimation and things to try and figure out. Also, was it accidental or purposeful? Were they just in a lot of pain and they took, 4 to 6 pills every 4 hours because they were having so much pain with their Vicodin or their whatever pain medicine, versus just 2 that was prescribed? Or was this person intentionally trying to attempt suicide, so they took 12 or more? And getting a good history, and you can see why that's really important. Also, prior treatment before they came to the emergency room or to the hospital. Did they try to throw up? Did they drink milk or fluids? Was syrup of Ipecac used to try and make them throw up? Some of the basic things from that Poison Control Center website we looked at, you can have the phone number or get on that website. The first aid for poisonings: if they collapse or have a seizure, you need to call 911. Inside the hospital, if something like that's happening, you're going to either call a code to get the code team there, or RRT, which is Rapid Response Team, which many hospitals have this in place if your patient is just declining and you need somebody to come and help you assess and do something actively before somebody has to be called to do CPR or call a code. If you can call an RRT, that's a good thing, because it really helps keep you from having to do CPR on somebody, it might save them sooner and get them to the right care. So on a rapid response team, there's going to be a nurse, a respiratory therapist maybe, and they come and help you extra assess your patient, figure out what needs to be done, help you prioritize, call the doctor, or decide, yes, let's just call a code. So it's just having an extra set of nurse brains there to help you with. Okay, also if you swallow poisons or have poison in the eye or poison on the skin, like rinsing and moving your taking those clothes off that are with poison on them, rinsing your eyes immediately. If it's swallowed poisons like a burning or irritating or caustic material, and the people aren't seizing, they might be able to drink a little bit to just get the amount out of their throat from burning, and then call 911, or, of course, and bring that product with you if you're with somebody who has ingested it. On syrup of ipecac, it's a product that people used to keep around because it caused vomiting, and it was used to help empty the stomach, but they don't recommend that. The issue with it, if you take this syrup, it's going to cause you to throw up for quite a while, and so that's, sometimes you don't want that because that substance coming back up might be worse, or you might aspirate. We give charcoal a lot of times, activated charcoal, to absorb the poison and help get it out through your digestive tract. We'll talk about that just a little more later, but if you have given this syrup of ipecac and then you put the charcoal in, it's not going to absorb anything because you're going to be throwing it up the whole time. So that charcoal won't work to inactivate the poison. So, okay, gastrointestinal decontamination is on to the next one there. That's all the syrup of ipecac, which I already just talked about. What we want to do is prevent absorption, and that's our first goal. We just talked about why vomiting might not be the right thing. You might not adequately empty the stomach. You can aspirate. You can have a risk for stomach or esophageal tear because of the severe vomiting, especially with syrup of ipecac, because it can last from 60 to 90 minutes. And it's going to delay your activated charcoal treatment because that won't stay in and absorb the poison. So gastric lavage is a better, more accepted thing for recent ingestion. Recent ingestion means an hour or less since the time of ingestion. The pills might still be in the stomach there. You get it prior to going to the small intestine. There's a large gastric tube. It sucks pills out, and it needs to be big to get them out. And there's a three-way stopcock or mechanism on there. And you pull a plunger back, this two-sided plunger that you see in the little picture. Then you push it forward, and as it pulls back, it's pulling stomach contents. Then as you push forward, it's emptying the contents into a waste bag, as well as taking some of the clean fluid and from the other bag, like the lavage part of this, and putting it into the stomach. So then you do the pull back again, and you're going to pull what you just put into the stomach and hopefully back with pills or parts of pills. And then it pulls another set of clean fluid into the other side. And then as you push, it pushes it into the waste bag. So each time you're doing this, you're irrigating the stomach in and out. And you want to be documenting there were a lot of pills or dissolved pills and parts of pills. You check placement with this, like an NG tube. The risks are aspiration, increased vomiting, and risk of electrolyte imbalance. Because you're pulling fluid out of the stomach, and that can cause the electrolyte imbalance. There's a risk for stomach or esophageal perforation, distension, or bad tube placement. So again, the guidelines is going to be an hour or less since ingestion of the toxic drugs. Then you also have to think of the risk-benefit ratio if it's been just a little bit over an hour. But for testing purposes, I'm telling you, it needs to be 1 hour or less than 1 hour from the time of ingestion. In real life, they might try this anyway, just to give it, see if there's any pills in there, based on the people giving the history. But for testing purposes, 1 hour or less. That's when you can use gastric lavage. Okay, now we're going to go talk about activated charcoal. We're going to do the same thing with this 1 hour or less since the ingestion time history. So pills are still in the stomach, and what happens here with the activated charcoal is it actually binds to the drug or the toxins and absorbs it, and then it comes through the GI tract, through our digestive system, and it's not able to be absorbed there in our digestive system. Of course, the golden hour is this first hour. Most patients maybe aren't going to go to the ED in that time, maybe, so that can be a problem. Activated charcoal is given, again, maybe a little over an hour, but if you see this on the test and it says the patient ingested, an overdose of this at 2 hours, don't pick activated charcoal and don't pick the gastric lavage because it needs to be an hour or less for testing purposes. Okay. I went over that enough. Some other things about activated charcoal. It tastes bad and it's really clumpy. So adding flavor to it is really nice because you don't want to punish somebody. If they were already like trying to commit suicide and took a lot of pills, or it was just a mistake, you want to make them able to drink this down. So maybe adding a little soda with it would help. Also, it being clumpy, you have to really mix it well. That if they're not awake, they might have an oropharyngeal tube or an NG tube placed and checked well before they give this that way. This activated charcoal will not work with iron or lead or lithium or corrosive agents, hydrocarbons. You can't use it with those kinds of metals. And wonder, well, who's going to be overdosing on lead or iron? With lead, and especially in older homes, it used to be kids with lead paint, like whatever, they're tasting the window ledge, or I don't even know, but that's how they used to warn you about that, and in older homes especially. Also, with iron, multivitamins, the gummy kind or the kind that look like candies, that can be a problem and can cause an overdose of iron. Another contraindication is going to be if they have decreased bowel sounds or something where the GI tract is not working right, if it's too slow, because it has to move through to get the toxins out. This activated charcoal has to be able to get through, and it's not going to work if it's just sitting there in the GI tract. So it has to be able to be working to excrete the activated charcoal bound to the drug. You may be giving this intermittently. Let's see. For some drugs, especially long-acting or extended release, if that's the toxin that was the overdose, you might need several doses over time to make sure you're getting all of it out. Let's see here. They might give it with a cathartic like sorbitol to cause diarrhea. That's not technically endorsed, but it may not hurt. It may help you excrete quicker. Complications are aspiration of the activated charcoal, especially if they have the NG tube. We want to make sure we have suction available. And let's see, we talked about the complications a lot already. Okay, hemodialysis. This is another way to get rid of toxins. There's this list of drugs here that may warrant hemodialysis to get rid of the toxin: acetaminophen, alcohol, antibiotics, potassium salicylate. This list is not exclusive. It's just showing you a few things, and you may see dialysis being used for this. It, of course, removes the blood and is run through filters for cleansing and then given back to the patient. They would have a temporary hemodialysis catheter placed. This picture is showing a real fistula, but they would give you a line usually placed in your subclavian vein or up in your neck. They might have a line placed for this. All right, now we're going to go on to metabolism of acetaminophen, which is also Tylenol. Let's see, if it's absorbed, we talked about using hemodialysis. There's two routes that can metabolize acetaminophen. The major pathway, where the metabolites are non-toxic, and the minor pathway. If you are drinking alcohol, the liver produces more CYP 450, or if you take way too much acetaminophen, it can go to this minor pathway, and that leads to toxic metabolites. So this glutathione is where it says depleted by alcohol and acetaminophen overdose. That's what fixes the toxic metabolites normally when this minor pathway is used. But if you've overdosed or are drinking a lot of alcohol, you don't have a lot of this glutathione around, and so it cannot get these toxic metabolites reduced to non-toxic. So acetaminophen overdose, the important thing is the first 24 hours, the symptoms aren't that, you don't see them that bad. They're just upset stomach, nausea, vomiting, lethargy, malaise. Then in the next 24 to 48 hours, liver damage might be starting, and you might start having some of that right upper quadrant pain. A lot of times at this point there's not really strong symptoms. Then at 48 hours or more there is confusion, lethargy, coma, jaundice, right upper quadrant pain. These are all signs of liver damage. So what are we going to do? Well, if it's an hour or less, we're going to give the activated charcoal. We want to do gastric lavage. Also, we want to do labs, check liver enzymes, a BUN, which is checking the kidney function, glucose, and for the acetaminophen level to start out with, which is very, very important. Then a 4-hour level after that for the acetaminophen level. And the reason for getting a 4-hour level on the acetaminophen is it's going to guide what kind of treatment you're going to do for this patient. If the level is high enough to cause liver damage, then they give this N-acetylcysteine or Mucomyst orally or IV if it's indicated by the nomogram, which is on the next slide. So you're looking at every 4 hours you might be giving doses of this Mucomyst or acetylcysteine, depending on that level, and that's going to guide your treatment. It can be up to 12 or 17 doses, so you might be several days of time where you're giving this. Mucomyst or N-acetylcysteine is normally used for respiratory issue to thin mucus. It's a mucolytic. That's what its purpose is. It protects the liver by replacing this glutathione that we talked about in the body. So then the toxic metabolites can be changed to non-toxic metabolites. Okay, let's go on to this nomogram right here. And let's see, it's the treatment for how to treat for acetaminophen toxicity. You see for a level of 150 or less, it's likely safe. So they're showing this at the 4-hour level, you get 150 and you're probably safe. At the 8-hour level, if you get 150, you're in the probable toxicity treatment side. So then you see also here the 150 to 200 range right in the middle here that says possible toxicity treat. Some factors to decide whether to treat or not treat are going to be if they've had an overdose before, or if they have a liver issue, or if they're just healthy and had some issue where they got overdosed for some reason. So if they're healthy, they might just wait and see what the level says at the 4-hour, if they're coming out in this range at the beginning. And so also what can happen is you can be testing, you're at 150, so you're okay, and then down here say your level is 70, so you're okay, and then you get to the 12-hour and all of a sudden you're up to the 100, it's going up a little, so then you're in this need to treat. So it's important to go over the hours and use this to help you decide on the treatment. And then you see at the beginning here, 200 or more, they're going to treat right at the outset. So if they're overdosing on Vicodin, which is oxycodone and acetaminophen, not only are you going to worry about the acetaminophen level, you're going to worry about that opioid, about the oxycodone. So you have two toxicities that you might be having to deal with at the same time. This goes back to also teaching. Excuse me. You know, patients about doubling up, sometimes they may have had a surgery and they are given this prescription and they don't realize taking extra acetaminophen on top of their oxycodone with acetaminophen is going to really double up that amount. And also, let's see, we talked about those levels already with the 4 hours. All right, salicylate overdose. This is an acid type drug. It increases the body's metabolism when you have an overdose, and with increased doses you'll get tachypnea to blow off that extra acid. You will get diaphoresis, hyperthermia, tinnitus or tinnitus, however you like to say that. So you want to teach the patient about some of those symptoms, because if they go home with aspirin and all of a sudden they start having ringing in their ears or nausea and vomiting, they might be getting too much aspirin. With overdose, you'll also, when it's severe, you'll have altered mental status, hemorrhagic gastritis, coagulation abnormalities. We know it's an anticoagulant and it can irritate the gastric mucosa, so you're having both a system issue with the bleeding and a local issue with the ulceration. Supportive care is what we want to do, so cool them down if they're hyperthermic, give them hydration. If they're tachypnic, we want to take care of making sure they're oxygenating properly. You want to draw electrolytes and make sure that you replace those as needed, put them on seizure precautions. Also, giving activated charcoal, maybe in multiple doses, especially if it's an enteric-coated overdose. It might be getting in their system over time, so you might see those levels rising later. For blood testing, they usually the first one and then at 2 hours after the initial draw. And then if that's not too high, or if it's not bad at the 2 hour, then they go to every 4 to 6 hours. The level doesn't peak until 4 to 6 hours with aspirin, so another way that they can take care of this is by alkalizing the urine. Doing that makes the acidic aspirin ionized, so that at the kidneys and the renal tubules there's not going to be reabsorption, just excretion. If you are alkalinizing your urine with sodium bicarb, which is a base, your blood might also be getting more on the alkalinized side, and that will help to make the aspirin ionized and not be absorbed. Also, they might use whole bowel irrigation with polyethylene glycol. That's especially with the enteric-coated kind. Or if activated charcoal was given and you're not seeing aspirin levels drop, that's another reason to go to whole bowel irrigation with polyethylene glycol. All right, we're going to go on to digoxin overdose. There's the nice flower there, a foxglove plant. That's where dig comes from. It's used for heart failure, slows the heart rate, and helps it beat effectively. If you get too much, you're going to get bradycardia, profound bradycardia. You can also get confusion, nausea and vomiting, visual disturbances, blurred or yellow-tinted vision. That's why the picture of Van Gogh is here, because they thought with many of his pieces were they were very yellow, and they thought he might be digoxin toxic. It can also cause cardiac arrhythmias, heart block, ventricular tachycardias, but heart block and the bradycardia, they have really slow rates, and that's a big one you want to worry about. So they'll be checking the digoxin level immediately and at 6 hours. If it was a PO dose, that we would give activated charcoal because we know it's in the stomach. If it's an IV dose in the hospital, we can't use charcoal, activated charcoal, because it's not going to bind because it's in their IV, not in their stomach. It's in their vein already. It's going to work with an IV overdose. So again, you draw electrolytes, real important to correct because there's going to be imbalances, especially with potassium. Also, the immediate digoxin level, you're going to need to know what it is, and then they're going to do another one at 6 hours. You're going to have them on a monitor because you're watching for those arrhythmias and make sure they're not going too slow. The antidote is digibind, and it binds to digoxin. Adverse effects that can also cause decreased potassium, so we want to watch that and watch the dysrhythmias. Atropine is a drug they give that combats bradycardia. It makes you have an increased heart rate. But for severely decreased heart rate or some of those heart blocks that make you go really slow, you might need a temporary pacer. The temporary pacer is this box, and it has the ability to set the rate that you want with this. What they'll do is put a sheath or some kind of entrance into the vein, into the venous system, and then they'll float this. They'll send this wire down there. it has a little balloon. Some of the types have a little balloon to help you float it down to the right ventricle. And then they do some testing to make sure that the energy delivered is hitting heart muscle and actually is able to cause the heart to beat at that faster rate that you are trying to run with this little box. So let me make sure I got all of that. Okay, so benzodiazepine overdose. Some examples of benzodiazepines, we give them a lot in the hospital. Temazepam for sleep, lorazepam for anxiety, midazolam, also known as Versed, for sedation during procedures. You'll see your patients come back from procedures sedated a little, like GI lab, cath lab, endoscopy, radiology. If it's a longer invasive procedure, they might have had this. Sometimes they get too much, and it's going to result in decreased respiratory rate or respiratory depression, decreased blood pressure. If we gave it and we know that's why they have too much in their system, we can reverse it. But there's also the need to do a lot of assessment. Somebody who is frail or elderly, they might it might get ahead of you. So give just a little at a time is good for older people. You want to look at other history with people who have too much sedation from any of these benzos. Excuse me. Their metabolism, is their alcohol use, so their liver's not working. Other reasons for too much sedation, like being frail or already have had other medications from at home that are causing more issues. So supportive care, again, ABCs, watch their airway, watch their mental status for changing, watch what their blood pressure is doing, and treat those things as needed. IV fluids for blood pressure. If their respiratory rate is so depressed that they're just not oxygenating at all, and we've already reversed the sedation, they may need to be intubated. You may need to give activated charcoal if it was a PO ingestion. The IV reversal is flumazenil or romazicon. It's this 0.2 milligrams dose that's not needed for the testing purposes. It's a small dose. Sometimes it's diluted in a bag, and it needs to be titrated because what happens is they might wake up a little and they're doing fine, and then or the benzodiazepine outlasts the reversal, and so you might need to dose them again. Also, you need to do a lot of assessment and watch how they're acting, because you might need to give another dose. Okay, now on to narcotic overdoses. Okay, so we're talking about the opioids and narcotics. The opioids like fentanyl, morphine, Dilaudid, also people on the street with like heroin or something like that. If we know it was IV, we can give them naloxone or Narcan as the reversal. If it's on the street, and they also have the nasal spray to save a life, reverse it if you can. And they give it pretty quick, over 30 seconds. See, you might need more than one dose again, because the narcotic can outlast the reversal with naloxone. That's why reassessment is important, just like we saw with the other one. They might wake up, they might be doing fine, and then they start to get overly sedated again, and so you have to give another dose. For preventing overdoses, we want to keep chemicals out of reach. Labeled accurately, not changed from the bottle they came with, so children can't get a hold of things. Also, you need to be able to assess your patient, all those history things we talked about. Whether you're giving medications to people, a 98-pound frail elderly person versus a 250-pound young 20-something healthy weightlifter, that's going to be a difference in dosing. Start low and titrate. It's always okay to give a little more if you need it, but it's really super hard to take back what you already gave. So start low and then titrate as needed. This concludes our lecture on poisonings and overdose. Thank you very much.